Morning, good afternoon, good evening, based on where you are joining us from today, and welcome to today's webinar. My name is Laura Ceci-Galanos. I am the Executive Manager of the World Stroke Academy, which is the educational platform of the World Stroke Organization that provides stroke education to health professionals worldwide. It is with great pleasure that we are hosting this webinar, this educational activity on advancements in Moyamoya disease from diagnosis to treatment. And we are lucky to have exceptional speakers that will be sharing their expertise on the topic. Also, a warm welcome to those of you that have joined us through the WeChat broadcast. Thank you for being here and listening in to the presentation. Now, before introducing today's chair and today's moderator, very quickly, a look at some of our housekeeping rules. We always welcome any questions that you might have throughout the webinar, but we kindly ask you to use the Q&A box for those in your Zoom control panel. So not the chat for questions, but the Q&A. You can, of course, use the chat box to let us know where you are joining us from, your country, to say hi or leave your comments. Also, a reminder that this webinar is recorded and the recording link will be sent out to you via email shortly after the webinar, and it will also be uploaded on the World Stroke Academy, so you can rewatch it at your own time. And lastly, we kindly invite you to fill in the evaluation survey at the end. It will pop up on your screen once the webinar ends, which is a way for you to share your feedback with us, let us know what other topics you're interested in, but also a way for you to claim your certificate of attendance for today's webinar. Now, without further ado, let me introduce today's chair and moderator, our World Stroke Organization President, Professor Jeyaraj Pandian. We thank you for being with us today, and the floor is all yours.
Yeah, thank you, Laura, and welcome everyone for this webinar on advancement in Moyamoya disease from diagnosis to treatment. Just a quick background I want to share. During my recent visit to China in Beijing, I was interacting with a few neurosurgeons, and they were doing so many surgeries for Moyamoya. Then I asked them how many surgeries your center has done, and he conveyed to me that it was more than 10,000 cases, and some of the centers in China are referral centers for the entire country. And we know Moyamoya disease is a progressive cerebrovascular disorder, and it has higher predilection in Asian countries, particularly East Asia, South Asia, and there are several challenges. The patients can present at a young age, multiple strokes, and many times there are treatment dilemma, both medical as well as surgical. And today we have eminent faculty from China and India, and they have a large experience in handling these type of patients, both children as well as adults. And we are going to hear from them. And so as mentioned earlier, if you have any Q&A, if you have any questions, please post it in the Q&A box. And so I am privileged to introduce our first speaker. Yeah, so Professor N Sylaja, she's the head of Comprehensive Stroke Care Program at Sri Chitra Tirunal Institute for Medical Sciences and Technology from Southern India. Her center does a lot of Moyamoya surgeries in our country, and they are the highest in terms of the volume of patient that they manage. So she's going to give us an overall view about the clinical presentation of Moyamoya disease and also about epidemiology. So to Dr. N Sylaja.
Thank you, Dr. Jeyaraj. Thanks to the World Stroke Academy and Dr. Jeyaraj for the invitation to be a speaker in this Moyamoya webinar. I will just share the slides. So Currently, I'm in charge of the stroke care program at our center, and we are one of the centers doing a lot of Moyamoya surgeries. In my presentation today, I'll be speaking on clinical presentation of Moyamoya disease. So I'll just briefly go through the epidemiology, the Moyamoya disease versus Moyamoya syndrome, the clinical presentation, and the natural history. As you know, the Moyamoya disease is a cerebrovascular steno-occlusive condition characterized by progressive stenosis of the terminal portion of the internal carotid artery, and there is a formation of an abnormal network of dilated fragile perforators at the base of the brain. Currently, there is a new definition from 2023, which was developed by the research committee of the Moyamoya disease, wherein there should be the steno-occlusive disease is centered around the terminal portion of the internal carotid artery, but in the absence of other causes, so that you need to rule out vasculitis or intracranial atherosclerotic disease to say that it is a Moyamoya disease. Compared to the previous definition for Moyamoya disease, it was mandatory to have bilateral involvement of the ICA, but the revised definition includes unilateral disease also, because as you know, sometimes when you see the disease in the early period, it may be unilateral, but later you may find that the patient is having, on follow-up, you may find the involvement of the other side. And also, it is not mandatory that the distal ICA should be involved. Patients may start with involvement of the proximal M1 and or the A1 of the anterior cerebral artery, and the patient may develop later involvement of the internal carotid artery. So these are the revisions in the definition. So let us look at Moyamoya syndrome and Moyamoya disease. So in Moyamoya syndrome, the diagnostic criteria is the same as I mentioned for Moyamoya disease, but in addition, the patient will be having other comorbidities associated with the vasculopathy, like a vasculitis or a patient with having other systemic connective tissue disorder or a Down syndrome or a sickle cell disease or a neurofibromatosis. If these are present along with the Moyamoya disease, you put it as a Moyamoya syndrome. So in Moyamoya disease, none of these coexisting medical comorbidities are present, and it is neither of atherosclerotic or inflammatory origin. Looking into the epidemiology, as we all know that there is a very low incidence of Moyamoya disease in the European and the North American population, as you can see here, and it is mostly concentrated around the Japan, Korea, and the Chinese population. So it's mostly a disease in the East Asian population of Moyamoya disease. If you look into the incidence, as you can see here, compared to the Japan versus the Caucasian population, the more patients are with the women. But if you look into the major difference is that the family history is less common in the United States compared to the East Asian population, where the family history is up to the tune of 10 to 15%. And if you look at the age distribution, there is a bimodal peak, wherein the peak is around the age of 10 years and around 40 years, compared to the Caucasian population, where it is mostly into the adulthood. This is one of the Korean nationwide population-based registry, just to show the peak of the incidence of the Moyamoya disease by sex and age. You can see that the peak is around 5 to 14 years, and you may see it around the age of 45 to 54 years. And what are the different clinical presentations? So one is it may be asymptomatic. Second is patient may be presenting with an ischemic stroke or a TIA. Then third presentation is with a hemorrhagic stroke. And in others comes the patient may present with seizures or a headache, and very rarely they can present with cognitive issues and coriform movements. So if you look into the patterns of the Moyamoya disease at onset, there is a significant difference between the pediatric and the adult population. This is also from a Japanese large registry. You can see that in the pediatric population, almost 80% of these patients presents with ischemic stroke, with a very small percentage of the patients having a hemorrhagic stroke presentation. But if you look at the adult population, you may see that 50% of them are ischemic and around 25% of these patients present with hemorrhagic stroke. So there is a big difference between the pediatric and the adult presentation. This is also to show that what are the usual patterns. We usually see a lot of these pediatric patients presenting predominantly, rather than stroke, they present more with recurrent TIAs and with seizures. Sometimes they come with a combination of seizures and TIA. And only maybe when you do the imaging, you find that the patient has got both seizures and also stroke. And hemorrhagic stroke is a less common presentation in the pediatric age group compared to the adult population. You can see that the more common presentation is with stroke and with hemorrhage, and less common are the TIA in these patients and the seizures. And the same thing, this from the systematic review, if you compare the ischemic presentation with the hemorrhagic presentation, you can see that there is a significant difference in the presentation of the Japan, Taiwan, and the Chinese population, where you find that in the ischemic presentation, you find that it is more common in the childhood compared to if you look at the Caucasian population, the US population, you can see that the major difference is not there. And one of the important differences that in the hemorrhagic stroke presentation, in the East Asian population, you find that the hemorrhagic stroke presentation significantly dominates in the adulthood compared to the childhood. So let us see the asymptomatic Moyamoya. Asymptomatic Moyamoya is a condition where you see the Moyamoya angiopathy in the imaging, but you do not have a history of an ischemic or a hemorrhagic stroke or seizures in these patients. Why it is now increasingly being recognized is because sometimes you may see a family history of one patient presenting, and you may do a screening of the patients, and you may find that Moyamoya is a disease is there in the other family members. Second is sometimes you may see a patient has a migraine history or a headache which is continuously there. A physician does an MRI and they may accidentally find that the patient has got a Moyamoya disease. So this is one of our patients who is a 13-year-old boy with a normal birth and development with migraine for 4 years. Was seen by a pediatrician, did an MRI with MR angio top for the headache, and the patient was found to have a Moyamoya disease. Here you can see this is a diffusion and the ADC. You can see there is no acute infarcts, but you can see that in the MR angio, you can see there is a distal ICA with the proximal M1 and A1 involved. And here also there is almost an occlusion with a very reduced flow in the MCA. And this patient underwent an angiogram, and you can see that if you look at the right and the left, there is significant distal ICA stenosis with stenosis of the proximal M1 and A1, and also similarly on the left side, and you can see the perfusion imaging showing significant perfusion deficit. So this is one of the very meticulously done study of an asymptomatic Moyamoya disease MO registry, which is a 5-year stroke risk. Here you can see these patients were asymptomatic and the patients were followed up for 5 years with a primary endpoint of stroke. This is just to highlight regarding the importance of the revised definition. As you can see here, these are the typical Moyamoya patients where you see the distal ICA and the M1 and the A1 is involved. But sometimes you may see a patient has got a event, or even if the patient is asymptomatic, if you see in a pediatric age group, there is a M1 involvement, later you may find that they may progress to have a Moyamoya disease. So there is a typical and also the patients with a atypical presentation. So this is from the natural history of those patients who were followed up. 1.4% of these patients had a stroke. This was the annual stroke risk. And they found that the typical Moyamoya most often presented with stroke compared to the non-typical Moyamoya disease. And the presence of the grade 2 choroidal anastomosis and microbleeds were important predictors of both ischemic and hemorrhagic stroke in these patients. This is just to show the patients who have progressed in the asymptomatic Moyamoya. You can see this is a patient at the time of entry, and at 1 year you can find that here you can see that the distal ICA with the M1 is stenosed, but here you can see it is almost occluded. And similarly, this is another patient where at 3-year follow-up you find that there's a significant progression of the disease. So there is a significant progression of this disease, even though the patient remains asymptomatic. There is a very significant variability in the presentation. So this is a patient with the 8 years follow-up. You can find that there is a progressive steno-occlusive disease with no identifiable ischemic lesion on the MRI. So this is a presentation of an asymptomatic Moyamoya, but these patients require very close monitoring and follow-up and even do perfusion imaging. And if there is a perfusion deficit, these are the patients who may still need to be evaluated and undergo revascularization. Next group is a hemorrhagic Moyamoya disease. The usual mechanism by which the hemorrhagic Moyamoya disease happens is because of the rupture of the dilated fragile Moyamoya vessel or the perforating arteries, or it can be because of the rupture of the circle of Willis aneurysms, which may be true aneurysms, or sometimes it can be a dissecting or a pseudoaneurysm, which they present with either an intraventricular hemorrhage or a basal ganglionic bleed. All different types of bleeds can present in a hemorrhagic Moyamoya disease. But as I have previously discussed, it peaks in the age group of the adult age group of 30 to 50 years. But most important, we need to understand is that compared to the ischemic, the rebleeding risk in the hemorrhagic stroke is significantly higher. So this is also one of our patients. This is a 46-year-old female with no previous risk factors, presented with a right capsuloganglionic bleed with intraventricular extension. Patient recovered to a modified Rankin scale of 3. All the secondary workup was negative in this patient. This is the MR angiogram picture. And this patient underwent a DSA, and you can see that there is a distal IC and also the M1, which is occluded, suggesting that the patient has got a Moyamoya disease. And this patient underwent right-sided revascularization. And the patient, as the patient was waiting for the revascularization on the opposite side, within 2 months after this procedure, the patient had a massive bleed on the other side and the patient succumbed to the illness. So it's very important to recognize this group where the patients needs to be treated as early as possible. So this is also just to show you the natural history of the Moyamoya disease who presents with a bleed. The cumulative risk of rebleeding is significantly high. And it is in these patients, if you find a choroidal anastomosis of the anterior and the posterior choroidal anastomosis with the medullary arteries, if you see this kind of a picture, you can predict them at high risk of having a future occurrence of rebleed. So what are the factors which predict? You can predict these patients who are likely to go in for rebleeding. One is if the patient is presenting with intraventricular hemorrhage. Second is a posterior location of the bleed. And especially for Moyamoya disease presents with a bleed and the patient has got hypertension also or a smoking, they are at future risk of rebleed. And persistence of a periventricular anastomosis and choroid. You can see that the lenticular striate anastomosis here, you can see the lenticular striate anastomosis of the anterior and the posterior part. And in the source images, you can see that the anastomosis, and you can see that is exactly the same place where the patient had the bleeding. So if you have these kind of choroidal positive, and you find that these patients are at high risk when they have this lenticular striate anastomosis, they are at high risk of rebleeding. So now coming to the ischemic stroke presentation, most of these patients, especially pediatric age group, they present with ischemic stroke, or they can, many a time they present with transient ischemic attack, very frequent transient ischemic attack, and also seizure is a very common presentation in the pediatric age group, or they can present with minor or major strokes. And rare presentation is cognitive impairment and coriform movements. We rarely see. I have seen only one patient who had presented with a coriform movement in a ischemic Moyamoya patients. So ischemic presentation is common in both adult and the children, pediatric age group. This is another patient of ours who is an 18-year-old male who completed 12th standard, normal development with good scholastic performance, presented with recurrent neurological events since 2016, recurrent left hemispheric TIA at a frequency of 1 per month, and also started having later right hemispheric events. And this patient presented to us, as you can see here, the imaging even though the patient had very frequent events, the imaging did not show any significant ischemic lesions. And you can see that bilateral, the DSA shows bilateral significant Moyamoya disease. So this patient had a perfusion deficit, and this patient underwent left side followed by the right side, which showed a significant improvement in the perfusion in this patient. And the patient had bilateral Moyamoya surgery, and the patient is totally asymptomatic now. So there is this next group of patients. We tend to see a lot of these children at less than 2 years. They usually present with a more aggressive form. These are the patients we see with large hemispheric infarcts, and they have a fulminant course. Even before you try to plan the patient for the surgery, we find that these patients come with recurrent large strokes, and they need very early treatment. And when you see the imaging also, you find that there is advanced steno-occlusive disease in these patients with more limited cerebrovascular reserve. So these are the most difficult patients to treat, and it is very sad to see these patients progressing on to have recurrent bilateral events. The next entity is when they have a posterior circulation involvement. So if you see a posterior circulation involvement in Moyamoya disease, we can say that these are the patients with high risk of ischemic procedural complications. The last group of patients is the unstable Moyamoya disease. This is one of the most difficult patients wherein The patients present with the recurrent TIA and even minor stroke, you don't even have a gap period in which, and you know that these unstable patients are the patients where you ask them to be well hydrated, avoid strenuous exercise, you ask them to be, you see that the patients have at least a reduced event so that you can plan for the surgery. And these are the patients, when you plan surgery also, they have a very high risk of having peri-procedural events, and they have a rapid progression of these stenosis to occlusion and recurrent strokes. So this is a very, very challenging group of patients to treat. And so this is also one of our unstable Moyamoya patient who went on to have recurrent events, and but finally we could plan for the surgery for this patient, and the patient recovered without any neurological deficits. So to conclude, I would say that significant regional differences exist in the incidence of Moyamoya disease, both in the age and the sex distribution, also in the patterns of the disease onset. There is this group of asymptomatic Moyamoya disease. We need to understand that it is not a silent disease. There is a risk of ischemic and hemorrhagic stroke. You need to identify these patients with perfusion imaging and close monitoring and follow-up of these patients, and plan for surgery as soon as the patient need them. Next group is the ischemic stroke, which is the commonest stroke presentation, is ischemic stroke and TIA. And if a patient presents with a hemorrhagic stroke, please, we need to be very alert regarding early surgery because of the very high risk of rebleeding. And the unstable Moyamoya is a very challenging to treat and which needs focused perioperative management. Thank you.
Thank you, Dr. Sylaja, for giving an overview of the clinical manifestation of Moyamoya disease at different age categories, and also highlighting the importance of early recognition, and also the significance of asymptomatic disease. And so let's move on to the next talk that'll be delivered by Professor Zhang Qian, who is the Vice Director of the Second Ward of Cerebrovascular Neurosurgery, Department of Neurosurgery, Beijing Tiantan Hospital, China. Over to Dr. Qian. He'll be talking to us about surgical treatment of Moyamoya disease.
Thank you, Professor Padden. My topic today is the surgical treatment of Moyamoya disease. I'm from Beijing Tiantan Hospital. Dear colleagues, so my outline including a surgical indication, timing, and surgical approaches, advances in surgical treatment strategy. At last, I'll talk some cases. So first is the overview of Moyamoya disease. In this part, Professor Sylaja has talked a lot, so I'll omit this part. This is the pathology of Moyamoya disease is still unclear. Genetic factor or some immune response or hemodynamic alteration may contribute to the incidence of this disease. This is the epidemiology and the clinical manifestation. For diagnosis, we need DSA, MRA, CT, ACT perfusion, or SPECT. For treatment, there is no drug that can effectively control or reverse the progression of Moyamoya disease. Usually, antiplatelet therapy and statins can reduce the risk of ischemic attack. And also important is control the vascular risk factors. For surgery, revascularization is the important treatment for Moyamoya disease. So we can see during the past 5 years, many countries and areas has published their guidelines for the treatment and diagnosis of Moyamoya disease, this rare disease now is not as rare as before. So we can see from this guideline and some expert consensus for hemorrhagic MMD patients, the evidence is about grade B. The results from GEM study supports the RCT study support the surgical revascularization is effective to reduce the future hemorrhage. For ischemic Moyamoya disease patients, there is no high evidence, but for patients, usually we will use indirect or direct bypass to reduce the risk of future stroke. For asymptomatic patients, it was not routinely recommended for bypass surgery. So for indication, usually patients has ischemic symptoms or hemorrhagic events associated with disease. Moreover, impaired cerebral perfusion was confirmed. Bypass surgery will be applied. For timing, early surgery is recommended after a confirmed diagnosis. Delayed surgery usually in the following situation, including acute or subacute infection or frequent TIA attacks or acute hemorrhage. The operation will delay usually 1 to 3 months. For surgical approaches, the classic surgery is STA to MCA bypass. There were also many other kinds of indirect surgery, including EDAS, multiple hole surgery, or EDOS, EMS, EDAMS. For direct revascularization, we usually use STA to MCA bypass or occipital artery MCA bypass. The advantages for direct revascularization, including immediate improvement in cerebral perfusion and rapid relief of ischemic symptoms. The disadvantages is the technique challenging and the risk of cerebral hyperperfusion syndrome. When we do surgery, we need to consider the anastomotic shapes. We can use circle anastomosis, oval anastomosis, or fish mouth shaped anastomosis. For technique, interrupted suturing or continuous suturing, we can use. Also, recent some neurosurgeon reported the side-to-side anastomosis for treatment for bypass treatment of Moyamoya disease. Classically, we will use the end-to-side anastomosis. For bypass configuration, we can use a 1 donor, 1 recipient, or 2 donors, 2 recipient bypass, or 1 donor, 2 recipient bypass. This video shows the interrupted suturing for direct bypass. First, we need to fixing the donor and the recipient. So for interrupted suturing, we can use continuous suturing and interrupted tie the knots or loop technique. So Professor Xu may like this way. So this case in this video shows the continuous anastomosis. Continuous anastomosis is a little bit faster. In recent years, a Chinese team reported the side-to-side anastomosis results. In this patient, the donor is very thick, and the recipient vessel is the diameter is small. So use side-to-side anastomosis may reduce the occurrence of hyperperfusion. So except direct revascularization, indirect revascularization is also widely used. The common approaches including EDAS, EMS, multiple surgery, EDPS. The advantages including minimally invasive and technically simple, suitable for children or patients with poor vascular condition. The disadvantages is the delayed efficacy, or in some patients, insufficient angiogenesis may lead to limited effectiveness. This picture shows the procedure of multiple hole surgery. Is suitable for pediatric patients. This picture shows the EDPS results. Combined revascularization now is popular. STA-MCA bypass plus EDAS or STA-MCA bypass plus EDAMS was popular in China and also in Japan and the US. For endovascular treatment of Moyamoya disease, for intracranial artery stenosis related to Moyamoya disease, angioplasty and stent shows high restenosis rates, and it's not recommended for aneurysm in Moyamoya patients. The effectiveness of endovascular is comparable to non-MMD patients. In future, maybe we should pay much attention to the adjunctive therapy for these patients. This team from Korea reported multiple hole bypass plus the application of erythropoietin to enhance the results of bypass surgery and get a good results. So last, I'll show some presentation. The first case is a male, 54 years old. The patient suffered from dizziness. The diagnosis including Moyamoya disease and diabetes mellitus. The preoperative CT and CT perfusion showed multi-intracranial artery stenosis and intracranial hypoperfusion. The preoperative DSA showed bilateral Moyamoya-like change in both ICA. The patient underwent left side STA-MCA bypass plus EDAS. CT perfusion 3 months after surgery indicated significant improvement. So this DSA 6 months post-operatively demonstrated the patency of the STA bypass graft and can supply the MCA territory blood flow. So the MCA blood flow was mainly supported by the STA bypass graft. The second case is a female, 36 years old. She suffered from sudden onset of syncope for 10 months. The diagnosis is Moyamoya disease and right occipital lobe hemorrhage, and also cerebral infarction. The CT scan showed the right occipital lobe hemorrhage and multiple cerebral infarctions. The preoperative CTA and CT perfusion showed a bilateral hypoperfusion. The preoperative DSA showed bilateral classic Moyamoya disease manifestation. The patient underwent right STA-MCA bypass plus EDAS. This CTA was obtained within 1 week after surgery. We can see that after surgery, the right temporal and frontal, the temporal and the right temporal lobe was immediately perfumed by the STA. 6 months later, DSA was performed, demonstrated the patency of the STA bypass graft. While interesting, this case is different from the first case. In the first case, the MCA territory was mainly supplied by STA direct surgery. In these patients, the first week, the patient was supplied by the STA's bypass, while at 6 months follow-up, the indirect revascularization provide a much better collateral compensation. Case 3 is a female, 35 years old. The diagnosis is Moyamoya disease, cerebral infarction, and diabetes mellitus. The preoperative CT scan and the CT perfusion showed multiple infarction. In this patient, the MCA, ACA, and the PCA demonstrate severe stenosis. To reduce the risk of perioperative complication, we use indirect bypass for these patients. This post-operative CT scan and CTA results. This is the CT perfusion 4 months after surgery. The DSA 11 months at follow-up. We can see indirect bypass for these patients can also obtain a good collateral circulation. The last case is a children. Is a 3 years boy. The diagnosis preoperative is Moyamoya disease, cerebral infarction, and symptomatic epilepsy. The MRI and MRA indicated the classic manifestation of Moyamoya disease and multiple infarction. The boy underwent right side EDAS, combined multiple hole surgery on the right hemisphere. After surgery, the results shows a good circulation. For left side, the patient underwent multiple hole. This is the post-operative results of CT, MR, and DSA. 8 months after left side surgery, DSA demonstrated a good collateral circulation obtained in this patient. So summary, surgical revascularization is an effective treatment for Moyamoya disease. Each MMD treatment center should base surgical methods selection on its own experience, the technique strengths, and the patient's individual condition. Perioperative management and the prevention of complication should be emphasized. Timing of surgery should consider clinical status, infarct stage, and risk-benefit balance. So that's all. Thank you.
Yeah. Thank you, Dr. Qian, and for the excellent discussion about the various surgical approaches, including the techniques and also the indications for these surgeries. And thank you very much. So let's move on to the last speaker. It's my pleasure to introduce Professor Ben Xu, the cerebrovascular neurosurgeon from Fudan University, Shanghai, China. He's going to talk to us about the bypass by the 1,000 understanding the pressure after 16,000 cases. Over to Dr. Xu. Yeah.
Okay, thank you. Thank you, Professor Pandian. And today my topic is bypass by the thousands, understanding pressure after 17,000 cases. I'm Bing Xu from Shanghai Huashan Hospital. So our department have 800 beds, 40 operating rooms. We are both the WFNS and the ACNS training center. Last year, we have more than 21,000 operations, plus more than 4,000 gamma knife and cyber knife. We have 4 campuses in Shanghai. So this is my personal experience in bypass. By now, I have more than 17,000 bypass, totally in 122 hospitals in China and other countries. Now I have more than 9,000 patients are waiting for my treatments. Every week, I have more than 100 cases new registered for surgical treatment. So the success of the bypass depends on not only on anatomy, but also on understanding the pressure change. This is 13 years ago, a case of basilar trunk dissecting aneurysm with the subarachnoid hemorrhage, and this patient bilateral ICA was occluded. So this is a CT angel. You can see the ugly shaped dissecting aneurysm on the basilar trunk, and the basilar trunk is the only feeder for the whole brain because the bilateral ICA was totally occluded. So for this kind of treatment, we should guarantee the brain can have the enough blood supply.
It's not moving it.
Mm-hmm. So before we endovascular treatment of the basilar trunk aneurysm, we do the bilateral bypass for the hemisphere. So this is a first right side ECA, radioartery MCA, and the STA MCA double bypass.
Sorry, Dr. Xu, the slide is not moving, I think.
Slide don't moving?
Is it moving? Others?
Yeah,
No, it's not moving. That's what I was mentioning.
It's weird because my presentation on my computer is moving. Can you see the slides?
Yes,
Yeah.
yes.
You can see, but can the full view, full screen view can put here.
Now.
No, it is not. Yeah. We can see.
Okay. So the second surgery was on the left side, STA MCA double barrel bypass. Then after 1 week, after bilateral hemispheres bypass, we finally treated the basilar trunk aneurysm with a stent plus coiling. So we redo the angiogram, and we can find that the 4 STA MCA bypass was all patent, but the pressure in the radioartery changed a lot. So in this slide, you can see the STA MCA stoma was still patent, but the balance point of the pressure retreat into the radioartery. So the actual radioartery doesn't feed the hemisphere anymore. So because the delta P in radioartery was negative after 1 week. So actually this bypass was useless. So the underlying logic of the bypass hemodynamic, the first important is the Poiseuille's law. In this Pushoi's law, delta P is the only dynamic factor that determines the direction of the blood flow and drives the blood flow. The second is Bernoulli's principle. This is a law of the conservation of fluid energy. It's a basic principle of the fluid mechanics. And you can see a lot of this phenomenon. This is a AVM of the cerebellum, and after I occluded the ACA, you can see the pressure changed a lot, and in the V4 segment, you can see the blood flow was stopped. So in this V4 segment, the delta P in this segment is 0. So although the vessel was so patent and there's no blocking, but the blood flow was 0. So if the pressure difference is equal to 0, there will be no blood flow, no matter how thick the blood vessels are. So the classification of the bypass from a hemodynamic point of view, there's 3 types. The first is the flow replacement, which is the ECIC bypass for complex aneurysms, usually combined with the proximal artery occlusion, and also include the malignant skull-based tumors such as nasopharyngeal carcinoma invading the ICA and require the resection of the ICA to completely resect of the tumor. The second type is a borrowed flow from naval blood vessels, which is
can you move the slide? It is not moving.
It's not moving. Can you see the slides?
Yeah, after the video slide on the Poiseuille's law, you talked about nasopharyngeal carcinoma, so we could not see that slide here.
Now, can you see the slides of the classification of the bypass from a hemodynamic point of view?
No.
These slides? No.
Shailaja, do you see? Dr. Qian, can you see?
No, we can't see. We are still in that.
I couldn't understand what happened. So how about this one? Flow replacement?
It's not
moving.
Now
we
can see.
I think it is very slow. I think it looks like, yeah. The nasopharyngeal carcinoma you talked about, yeah.
Okay. So this is a nasopharyngeal carcinoma. You can see the bilateral ICA was totally invaded by the tumor. So I have to replace the bilateral ICA blood flow, use a bypass. So I do the ECA saphenous vein to M2 stoma. This is a ECA to saphenous vein stoma, and this is a saphenous vein to M2 stoma. And plus the ECA saphenous vein to M2, and I also do the double barrel STA M4 bypass. So after this kind of treatment, you can see the 3 bypass was all patent, and the 3 blood flow feeded the whole hemisphere, whole brain actually. But this is both side ICA was totally occluded after this bypass. So this is a tailored bypass for ICA invaded by malignant tumor or complex aneurysm. At first, we should estimate the nature collateral of the blood flow. So then we can guarantee enough blood flow replacement. So we will use 30 minutes balloon occlusion test. If the patient can tolerate very well, we will use the enhanced balloon occlusion test, which means the blood pressure would decrease to 30%.
Yeah. So sorry, I think maybe without the presentation mode, if you can show, that will be okay. I think it's not moving. Yeah.
So
yeah, maybe you can do this. Yeah.
I'm not sure where
I think some technical. Yeah.
So
maybe you can speak from here, probably. Yeah.
Sorry, I don't know what happened in your side, but in my side it's all okay. So the second type of the blood bypass is the borrowed flow from the neighboring blood vessel, which is the ICIS bypass. Like this is a big ACOM aneurysm, and we do the side-by-side A2 to A2 bypass, then occluded the right side A1. So this is actually after this kind of treatment, we combined with the one branch proximal occlusion. So the total blood flow actually after this bypass was decreased in double A2 territory. So the third type is flow augmentation. This is typically for Moyamoya vasculopathy. So this is a typical Moyamoya, 6 stages of the Suzuki. And this is a Moyamoya syndrome, MCA occlusion. And this is a special Moyamoya syndrome with Moyamoya plus AVM. This is another Moyamoya combined with the AVM. So we do the bypass and resected the AVM at the same stage.
Sorry, it's not moving. We are in the second borrow blood flow from neighboring blood vessels. Yeah.
Sorry.
Yeah.
But please let me going on because I don't know what happened in your side.
So, yeah, no, I think you no need to go to the presentation mode. In the slideshow itself, you just talk here. I think when it comes to presentation mode, then it gets stuck. After 2 slides, it gets stuck. Sorry about it. I don't know what that is.
So now can you see the picture? Can you see my slides now?
No, it is just coming. Yeah, we can see now. Yeah.
Okay, for Moyamoya patient, we can use 3 branch of the ECA, which is a STA or post-auricular artery or occipital artery of the scalp, anterior deep temporal artery or posterior deep temporal artery of the temporal muscle, and the middle major artery of the dura. So we normally use combined approach with the STA or posterior artery or occipital artery to MCA or ACA or PCA territory bypass combined with encephaloduromyosynergesis. So this kind of combined approach to allow maximum of the use of the 3 arteries. For the younger than 7 years old kids, normally we use a wide EDMS, so the follow-up result is good enough. Almost the same with the combined approach. So when the delta P is in a suitable range, this is a post-operating DSA.
I think it's not moving. Yeah, sorry. Yeah. How many slides do you have now? How many more slides? We can just see the slide view. Don't change to presentation mode. Yeah, you can talk from here. Yeah. You can just speak. Yeah. Yeah. Don't make it in the. You can speak from here.
Yeah. Can you see the movie?
It's moving. Yeah.
Okay. So when the delta P is in a suitable range, this is a post-operative 3D reconstructed DSA. You can see the blood flow come to the M2 segment, then redistribute the blood flow along the MCA territory. So Normally in the ICG intraoperatively, we can find the red T sign. On the left is a single barrel STA-MCA bypass. On the right side is a double barrel STA bypass. You can see the red T sign, which means a big difference of the delta P, and the bypass, this kind of bypass is sustainable. But when delta P is too small, you can see one short arm of T. You can see this is delta P is very small. So after this bypass, you can see after 1 week, the STA was almost occluded. So this is a borrowed case from Professor Zhang Qian. Sometimes when the delta P is too high, it can cause subarachnoid hemorrhage immediately intraoperatively. So to avoid the bleeding caused by hyperperfusion, the remedy is to use absorbable suture to narrow the feeding artery, decrease the blood flow in donor. So you can see in this patient, I use 160 absorbable suture, 170 absorbable suture to partially ligated the donor artery to decrease the delta P between the donor to the recipient artery. So intraoperatively, we can measure the blood flow in different vessels. And after the bypass, you can see the bypass in ECA branch.
This is not moving. You were in delta P is too small. After that, we did not see the slide there. Where you mentioned about delta P too large. What will yeah, now we can see.
How about this?
Yeah, we can see. Nova, we can see that.
Nova, you can see. Okay.
Yeah.
So this is a long-term blood flow change in different arteries. The blood flow in ECA branch was all increased, and the blood flow in ICA or basal trunk was all decreased. So this is the best possible outcome to cure the Moyamoya. You can see this is a young man after bilateral revascularization. The bilateral ICA was totally occluded, and the whole brain was fed by the ECA branches. So normally STA-MCA bypass was recognized as a low flow bypass, but if the patient got enough time, this is 7 years after bypass, you can see the whole hemisphere plus the contralateral frontal lobe was fed by the STA. In most cases, there's a competing between ICA and the ECA flow. So you can see the red flow was from ICA, the green flow was from the ECA. So between the green and the red, you can see this is a water shape between ECA and the ICA blood flow. And this is the 4D angiogram after the bypass. You can see the blood flow come from ECA branch, then to M2 segment, then redistribute the blood flow along the MCA network. So the determinants of the degree of the reconstruction of the cerebral blood flow depends on the choice of the surgical approach and the location of the stoma, and also depending on the severity of the Moyamoya vasculopathy. In different patients, ICA residual blood flow pressure is different, and also depends on the pressure balance of the blood flow of the ICA and the ECA. So this is a Venturi's effect, which means we can measure the pressure change, and then we can calculate the blood flow volume in the vessel. So we published this kind of pressure measurement in Moyamoya bypass. So this is an application of the direct donor recipient artery pressure quantitation.
Yeah, I think it's not moving now. So you were in what we see is determinants of degree of reconstitution of cerebral blood flow.
Okay, sorry. I don't know what slides.
Yeah, I think I think you can use the slide view and talk, and there are only a few more slides. So yeah, we can talk from here. Yeah, don't make it to the presentation mode. Yeah.
Okay, this is the detector of the pressure, and in every bypass we can detect seven pressure parameters. So because of the time limitation, I will skip this this presentation, and we also can check the pressure of the oxygen in STA and N4. So we find that after the blood flow going through the Moyamoya network, going to the M4 segment, we find a slope principle after this Moyamoya. So normally the M4 segment, the pressure was only 33 millimeter mercury, and the distal ICA was 85 millimeter mercury. So the pressure decreased so much after going through the Moyamoya network. So we can find there's two pressure gradient of the MCA network in Moyamoya disease. Actually, the first pressure gradient of the MCA is still keeps the physiological direction, which means P proximal larger than P distal. So we call this antigrade. This kind of patient occupied around 62.5%. But we also can find the second pressure gradient of the MCA, which is a reversed physiological direction, which means P proximal in M2 segment, less than P distal in M4 segment. So we call this retrograde. This is almost occupy 40%. So this is the exact data of the bypass pressure. So normally the mean pressure in recipient artery, in donor artery, is almost the same with the STA was almost the same with the monitored artery. So the recipient artery in different stage, actually you can see in stage 2 has the lowest recipient artery pressure. So the mean delta P is around the 62 centimeter water column, just like a little water fall. So you can see after the bypass come to the MCA network, there's a sudden drop in pressure from STA to M4. So this creates a very fast flow, just like a waterfall. Can you see the video?
Yeah, we can see. Yeah.
Okay. So this is the result of the measured pressure. STA pressure is quite high, close to the mean artery pressure. So after the anastomose, blood flow increase and the pressure gradient is reconstructed, and the pressure is reduced, which is in line with the Bernoulli's principle. In the recipient side, in line with the slope principle, the pressure of the distal M4 segment is significantly reduced after passing through the Moyamoya vascular network. And the pressure gradient, the distal blood flow pressure and the proximal pressure are not the same. And the two pressure gradient for the MCA network are approved. And a parallel bypass keeping the same direction of preliminary flow in the donor artery and as the recipient artery is reasonable. And we also published this kind of article. And between the donor and the recipient artery, the pressure difference is significant, average 46.4 millimeter mercury equal to 62 centimeter water column. So I call this a small waterfall. After the bypass, the pressure gradient was reconstructed to form a new ECIC watershed. So this is an inevitable phenomenon. Between the donor recipient bloodstream, there was a significant partial pressure difference in oxygen, averaging 13 millimeter mercury. So this kind of difference in the oxygen is essential for the formation of indirect anastomosis. And the pressure is very interesting. Actually, not only at the artery side, but also at the vein side. You can see at the right side of this picture, you can see the vein changed the drainage pattern a lot. So this is a turbulence in the vein, and the delta P between these two ends is small. So the blood flow was very slow in this segment, in this blue segment. And in the orange segment, the blood flow was increased. So even in same vein, the blood flow has different pressure and different blood flow velocity. And this kind of increase of the pressure in the vein sometimes is the cause of the naval cortex infarction. So the pressure detection is very interesting, and we are studying more and more. So the more you know the pressure, the closer you get to the goal, and we can get the more efficient bypass. Thank you.
Yeah, thank you, Dr. Shu, for highlighting the importance of pressure measurement and how you can improve outcome based on the flow. So there are a few questions. I think there was one question in the beginning to Dr. Sylaja about the Moyamoya disease, how common is in India, and are there any regional differences? Maybe you could address that, yeah.
No, actually, yes, Moyamoya disease is, even though rare, it's not that rare, I would say. We may be tending to see the patients more is because ours is a high volume center. Otherwise, I think it's still not very common as we see in China or Japan or Korea. So we are definitely lower, but maybe we are seeing more Moyamoya than we see in the Western population. Second is with regard to the ethnicity part regarding the different states. I would say that we have recently did a study looking at the RNF213 polymorphism, which is mostly seen in the East Asian population where the family history is more common. And we have found in 2 of those states, in both Tamil Nadu and the West Bengal population, we found the RNF213 susceptibility gene was more common in these places. And in these places, we found the family history also being positive. So there is definitely a ethnicity involved in these patients.
Yeah, thank you. There's a question about, do all your patients that have unilateral Moyamoya move on to have bilateral disease? If so, how long does it usually take for this to occur? And how often do you monitor with recurrent vascular imaging in these patients? It's a very important question. So all of you can answer, yeah. Maybe Sylaja, you can start and then...
One is, we tend to see, because there is a lot of heterogeneity in the way the Moyamoya disease progresses. Some of these patients who are with unilateral Moyamoya remain the same, but at the same time, you may see patients on follow-up who present initially with unilateral go on to have bilateral Moyamoya disease. So I would say there is a lot of variability. Even in the progression, there is a lot of variability. We could also see, I have shown few images from the MO registry where there was a progressive disease, which was very variable between a patient with a 1 year versus a 5 years. So what is most important is, even if you see a patient with unilateral Moyamoya disease, it is very important to follow up these patients to see whether the patient develops progression of the disease, also whether the patient has developed a disease on the other side.
Thank you. There's a question on medical management. Maybe I will ask Dr. Zhang to address that. Any efficacy on duration of double antiplatelet in recurrent ischemic stroke due to Moyamoya disease? Or maybe Dr. Qian, you want to address any role of 2 antiplatelet therapy?
Professor Patton, you mean the dual double antiplatelet?
Yeah, double antiplatelet. Yeah.
Yes, in Moyamoya disease patients for ischemic stroke, maybe adults, double antiplatelet treatment is effective. Sometimes for in adult patients, we need to make sure it's a Moyamoya syndrome or classic Moyamoya disease. Maybe for the patients from atherosclerosis risk factor, maybe this strategy is much better. So this is my opinion.
Yeah, thank you. Maybe the next question I'll ask Professor Binshu to answer. In cases of spontaneous dural synangiosis, would you prefer to go with revascularization surgeries? And if so, are there a risk of ischemic sequelae, ischemic stroke?
This is a very good question, and actually, normally in the late stage Moyamoya, especially stage 5 or 6, we can find some spontaneous stoma come from the middle artery, sometimes even from STA. So this kind of patient, we should analyze the angiogram before surgery very carefully, and we have a very good strategy to protect the STA, to protect the middle artery. We will create a double bone window, one in front of the MMA, one posterior to the MMA. So actually, because of the time limitation, I don't describe the surgical approach in this kind of patient, but in the books published in the surgical treatment of the Moyamoya vasculopathy, you can find it in my chapter.
Yeah, thank you. Yeah. So there's one question, probably the Moyamoya syndrome and Moyamoya disease. How will you differentiate? Maybe Dr. Zhang, you want to answer? Shailaja has just left, I think.
To differentiate between Moyamoya syndrome and Moyamoya patients is a very important and significant question. So for the combined disease, maybe help us to differentiate these two kinds of disease. For example, if the patient has some vascular or myelitis or NF1 or some other genetic disease, maybe it was more preferred. It may be a Moyamoya syndrome. Sometimes high resolution MRI may provide more information about the vessel from the vessel wall, help us to differentiate the disease. Also, the age of the patients, maybe for younger patients, the diagnosis may be Moyamoya disease. So this is my opinion.
Yeah, thank you. There is the last question that is about Is there an age limit beyond which performing indirect bypass is no longer meaningful? Maybe one of you could answer, maybe Dr. Shu, yeah. Any age limit for surgery, indirect bypass? Yeah.
It depends. Sometimes if the patient got very frequent TI, we would do the direct bypass. So my youngest age is around 3 years old. So normally if the patient in a very stable stage, normally normally younger than 14 years old, the EDMS, wide EDMS is enough.
Okay, yeah. So there's one question on cilostazol as a choice of antiplatelet for ischemic Moyamoya disease. Can we use cilostazol?
Yes, we can use, because if the patient got a very frequent TI attack, actually, I personally recommended the high bar oxygen treatment. So the patient got to take the high bar oxygen treatment. Normally, the TI can stop. Then after the TI was stopped, then we can do the bypass.
Yeah, thank you.
Yeah.
Sorry, continue, please.
If the patient still got very, very frequent TI, we will use some antiplatelet treatment and combined with oxygen, hyperoxygen treatment.
Hyperoxygen treatment. Okay, yeah, thank you. Thank you very much to all the speakers. It's a rare disease, but in East Asia and some South Asia, in other countries also we see. And I, on behalf of World Stroke Academy, I thank you all for joining and for giving us your time. And so over to Laura. Yeah.
Thank you very much. Indeed, warm thank you to our speakers. We apologize for the technical issues, and we thank Professor Bing Su for continuing his presentation, although we had these issues. We want to thank also our attendees for staying with us a little bit longer than anticipated. A reminder that we have 2 webinars upcoming in the month of September, which you can see here: antithrombotic therapy for atherosclerotic stroke prevention and optimizing antiplatelet strategies in stroke care. And of course, since October is approaching, a reminder for you to register to the 17th World Stroke Congress and join us in Barcelona, Spain. Once again, thank you for being with us today, and see you in our next webinar.
Okay.
Yeah.
Thank you.
Thank you. Thank you very much.
Thank you.
Thank you. See you.
Thank you. See you.